Scheduling's kind of very similar to the tribunal. So have a look on the back of the Section 19 form, that's the purple one, because that actually has the definitions under the Mental Health Act that you have to meet, and so just use those words.
If you're scheduling someone, you have to see the patient. So you can't kind of be given a form by someone and say, look, can you schedule that guy over there? You know, you have to go and visibly see the patient. And so if you're scheduling someone, that's an S19. And so that's, I guess, the first step in the process of making someone involuntary.
Scheduling's kind of very similar to the tribunal. So have a look on the back of the Section 19 form, that's the purple one, because that actually has the definitions under the Mental Health Act that you have to meet, and so just use those words. And so if they're in ED and you're the first person who's seen them and they haven't been scheduled or brought in by police or on an ambulance schedule, you need to do a 19, which is the purple one, and that's got all the information on the back. It's basically a cheat sheet, so that's great, and any doctor or like accredited person in ED can do them. And then if you're on the ward, you can be doing a Form 1, so that's the 27A or B, but they have to have a schedule in place for you to do that. And on the Form 1, so have a look at the Section 19 as your cheat sheet and then read through what the definition of mental illness is or mentally disordered, and then just write very specifically using those words how your patient fits that definition under the Act.
And there are subsequent steps to that as well. So I think, and it's the schedule can only, it's basically saying that this person needs further mental health assessment, and then you've got to have another doctor review the person, do a form. Ultimately, you have up to 3 forms, a schedule and 2 what it's called Form 1s done. All 3 have to be done by 3 different people.
I think this is one of the areas you kind of get better as you do it. It's important to have a good, I guess, baseline knowledge of the Mental Health Act. What can be quite helpful is there's a guidebook, New South Wales guidebook to the Mental Health Act. It's not a particularly stimulating read, but it's got some important information in there that can tell you when, what each of the sort of schedules, be it the police schedule, ambulance schedule from another colleague, what they mean and the durations of how long they're sort of valid for.
The one thing that you have to consider, and you have to always consider this, is it in the patient's best interests? Are you acting in the patient's best interests? I think that's the question that you have to ask yourself, particularly when there is temporary impairment in decision making. So if someone presents quite agitated from either intoxication or perhaps there is a crisis, you have to ask if is what you're doing necessary and in their best interests.
And really, you write what you see. So you write, patient is particularly agitated or they've got a very labile mood, and then you need to kind of package that into, okay, they've got these symptoms and how does that put them or others at risk? So it is all about risk. They will ask whether they think this patient is mentally ill or mentally disordered. And by mentally disordered, they're thinking, is this a temporary departure from the patient's baseline? Or do you think it's something a bit more persistent and pervasive that the patient needs treatment for an ongoing illness? And so certainly my advice would be write the symptoms, write what you see, and write why this puts them or others at risk, and hence your grounds for bringing them in under the Act.
The law has very strict criteria. The law is quite black and white. They have strict criteria as to when a person can be scheduled and cannot be scheduled. So if it's disordered, the person has to be at a risk of causing serious physical harm to themselves and others. So of course, if they're threatening suicide, or threatening to hurt someone, they're threatening or they're just behaving really bizarrely, and they're just kind of like, and you think they're going to hurt themselves or others, that's when they become mentally disordered. And for mentally ill, they have got to be either having hallucinations, delusions, a disorder of thought, a very severe disturbance of mood, like being very elevated or very depressed, or any behavior that suggests the 4 points outlined above. It doesn't matter to the Mental Health Tribunal or the Mental Health Act what causes those symptoms. So they could have taken lots of ice, amphetamines and become paranoid, but they have paranoid delusions, so they get scheduled as mentally ill. The law doesn't look at what causes those symptoms, the law only looks at symptoms. And I think in general that's what JMO should know, that they can schedule, and when you schedule, what you need to schedule as.
There are many specifics to do with how to apply the Mental Health Act. And I think when to use it is also a part of professional practice also. So, I mean, I can't give you any more comprehensive answer than that, but I think if you stick to, the first principle of always acting in the patient's best interests, then I think that's the foundation for good clinical practice.
And risks. Never forget risks.
It's good to be familiar with the Mental Health Act and scheduling. I think that's something every doctor should know, because you do have the power to schedule a person. Every doctor has. It's, I think, a misconception that only psychiatry registrars, only psychiatry doctors can do that. No. Psychiatry registrars are not specialists. They're just doctors as everyone else. And the different ways, like the ambulance personnel can schedule, a police personnel can schedule, but for doctors, what we use is a Section 19.
To have that understanding of how long a schedule is valid for, usually about 12 hours till they need to be reviewed, as well as the process afterwards in terms of a Form 1 and a Form B, can logistically be quite helpful when you're bringing a patient into hospital. What I mean by that is sometimes a patient will be scheduled on a Friday, and realistically they might not be seen by another doctor until Monday in some areas. So it's important to take that into consideration and to know that there needs to be a bit of follow-up afterwards. After you see this patient, after you've scheduled them, where are they going and who's going to see them next? So that would be one bit of advice I would say that would be helpful to know or helpful to plan for while you're scheduling someone.
There are different timelines as to how long you can detain them for. Like for someone who's mentally disordered, you can detain them for up to 3 working days. So it doesn't include the weekends, doesn't include public holidays. They've got to be reviewed every day by a doctor. It doesn't have to be someone from psychiatry, but they have to be reviewed every day by a doctor and have a documentation of their mental state and whether or not you need to continue the mentally disordered for now. And for mentally ill, there is a different process. If you want to detain them for a lot longer, you've got to go in front of a magistrate and the tribunal, and it's basically a method to protect patients' rights and to basically, it's just a check mechanism to make sure that people in healthcare aren't misusing their powers. And that's all there is to it.